Hello there. Let us find out what are the gingival and periodontal diseases. A quick glance at the content. The three zones of oral mucosa. Periodontium is made up of the gingiva, alveolar mucosa, cementum, periodontal ligament, alveolar bone. Gingiva is the mucous membrane with supporting fibrous tissue that overlies the crowns of unerupted teeth and encircles the necks of teeth that have erupted. Gingiva has three distinct parts: the marginal gingiva, the interdental gingiva, and the attached gingiva. In the picture, we can see it is clearly demarcated. Schematic representation of the gingiva: marginal gingiva, that is this part. Then we have the interdental gingiva. Okay, it's not in this schematic picture. And the firm gingiva. Attached gingiva is extending from here to here. Now let us see the differences. Marginal gingiva of a child has rolled edges, everted edges, rolled edges in primary dentition. It is more flaccid, it is more retractable due to immature connective tissue, and the gingival fibers are also immature, and increased vascularization is also there. Gingival sulcus is at the most 2 to 2.1 mm in depth in a primary dentition, and in adult it is more. Attached gingiva. It is tightly bound to the underlying periosteum of the alveolar bone, and the mucogingival junction separates it from the other mucosa. Attached gingiva is greatest in the incisor region in a primary dentition. Steepling. Steepling is the orange peel appearance of the gingiva. Now this is absent in child of less than 5 years of age. The interdental gingiva. Now in adults, if we remember from our study from organs, the interdental gingiva is called as caul. It is a fold of the tissue, pyramidal, and however in the child patient, what we see is it is shorter, more rounded, and appears like a saddle of a horse. This saddle shaped gingiva is common in children. Histologically, we have less abundant collagen fibers, and color is more or less reddish due to increased vascularity and thinner epithelium. Pre-eruption bulge, marked by the blanching in the picture this region. So, as the crown penetrates the oral mucosa, marginal gingiva and sulcus develop. These were absent when the tooth was not there. So this becomes edematous, rounded, and slightly reddened. Near the maxillary anteriors, we have the gingival prominence till the teeth are fully erupted. Let's do a quick summary of the points of variation between the child's gingiva and adult gingiva. So, the child's gingiva is pale pink, it is smooth surfaced, it is thick and rounded. We have keratinized saddle area. We have interdental clefts because the interdental spacing is more in child's teeth setup. The retrocuspid papilla is there, and the alveolar mucosa is red, thin, and vascular. White periodontal ligament, gingival fibers are immature, and the bone trabecule are thick with large marrow spaces. Coming to the gingival and periodontal diseases. Gingivitis is simply inflammation of the gingival tissue. However, there should be no loss of attachment or bone. Now there are many contributing factors also. Some are written here. Stages of gingivitis. Stage 1, stage 2, more common in child patient, more commonly seen. Types of gingivitis. Plaque-induced gingivitis, gingivitis due to habit, eruption gingivitis, infective gingivitis, herpetic gingival stomatitis, and HIV-associated gingivitis. Other types are acute necrotizing ulcerative gingivitis, malnutrition-induced gingivitis, pubertal gingivitis, drug-induced gingivitis, and plasma cell gingivitis. There are other types of gingivitis also, like the allergy-induced gingival inflammation and gingivitis due to candidal infection. Plaque-induced gingivitis. There's a simple gingivitis because of plaque. So if you remove the plaque, the situation is reversible. Healthy periodontium, supragingival plaque accumulation gives gingivitis. This process is reversible. However, if no treatment is given, this will become irreversible periodontitis. Gingivitis due to habit, seen in individuals with mouth breathing, especially the upper anterior. This is a type of transient gingivitis. Now, as soon as the teeth is fully erupted, this subsides itself. So we just have to wait and watch. Herpetic gingival stomatitis. It is caused by the HSV virus and sometimes also called as recurrent herpes labialis because commonly seen over the surface of the lips. Lower findings are erythematous involvement of gingiva. Discrete spherical gray vesicles can be seen as in the picture in the inset. Lip excoriations are actually painful and hemorrhagic. Now the course of the disease is for 7 to 14 days. Oral symptoms also include generalized soreness. Ruptured vesicles are the focal site of pain. Infants show irritability and refusal to eat. Obviously they are in pain, so how can they eat? And also pain upon swallowing. Extraoral symptoms may also include cervical lymphadenopathy, fever, generalized malaise, and irritability. Treatment is mostly palliative. However, we can also give diclonine hydrochloride 0.5%, which will be a mild anesthetic. Bed rest is recommended with soft diet, and definitely we must keep an eye on the hydration level of the child. Pyrexia can be treated by simply giving paracetamol or ibuprofen. Sometimes chlorhexidine mouthwashes, if can be performed when the child patient, can also be administered. Antivirals such as acivir or acyclovir, famciclovir, valciclovir can also be given. Acute necrotizing ulcerative gingivitis or ANUG, also called as Vincent's infection, Vincent's disease, was first seen in the trench warfare era in the World War I. Uncommon in children, however, occasionally seen in 6 to 2-year-old children. Predisposing factors are poor oral hygiene, pre-existing gingivitis, and sometimes accentuated by smoking. Systemically, the child is in some sort of emotional stress, maybe a survivor of child abuse or child neglect, might be having some sort of vitamin B, C, or C deficiency. The main organism behind is Treponema vincenti, Borrelia vincenti, gram-negative fusiform bacteria. Clinically, we can see in the picture. Clinical features. Characteristic lesions are punched out, crater-like depressions at the crest of interdental papilla. Surface of gingival crater is covered by a pseudomembranous slough. When removed, there will be an underlying bleeding. Linear erythema, inflamed painful bleeding, gingiva, poor appetite, fever, fetid odor, like you see in the treatment. Debridement under local anesthesia, remove the pseudomembrane, surgical curettage, diet counseling, proper instructions on oral hygiene, and systemically we can give antibiotics. Chloroxidine mouthwash can also be given. Non-specific chronic gingivitis or gingival disease associated with the endocrine system. Puberty gingivitis is a distinctive type of gingivitis that occasionally develops in children in the prepubertal and pubertal period, more so in the female child as compared to the male child, 11 to 14 years age group. Now, usually what we see that enlargement confined to the anterior segment. However, it's not a thumb of rule. The gingival enlargement was marginal in distribution, and in the presence of local irritants was characterized by prominent bulbous interproximal papillae. Treatment institutes proper oral hygiene, remove all the local irritants, plaque, adequate nutritional status has to be maintained. However, if the case is of a severe hyperplastic gingivitis, which is not responding to the local therapy, then we can opt for gingivoplasty.